There we go. It's recording now.
Thank you. Hi, everybody. We're a couple of minutes away from starting, so we'll give everybody time to join. So we had 70 registered. You never usually get everybody, but still, that's 70 people expressing interest. So that's great. Hello, everybody. People are still joining, so we're a couple of minutes away from starting. But you're very welcome. Probably not time to go and get another cup of coffee. But, I never really know how the system copes when everybody arrives at exactly the same minute. So it's just 8:30. We'll allow when people are joining. So we'll wait just a few minutes to make sure. So I'm going to start welcoming everybody. I'm Christine Hancock from C3 Collaborating for Health. We're a small global charity, if that's not an inconsistency, headquartered in London, but working globally, aimed at preventing chronic disease with a real focus on those risk factors that drive ill health. Traditionally, many years ago, everybody thought this was a rich country's problem, but 80% of preventable deaths are now occurring in lower middle income countries. So we're really delighted to hear Dr. Yoseph Mamo from Ethiopia, but we're also very delighted. He's the regional director for Ethiopia for Global Health Partnerships, good friends and colleagues of C3. And so I'd like to invite their chief executive, Ben Sims, to join us and to start the process. Ben, over to you.
Well, thank you so much, Christine. My name is Ben Sims. I'm Chief Executive of Global Health Partnerships, which is a small, medium-sized charity with much to learn from you, Christine. So it's wonderful to be invited to collaborate with C3 on this webinar. Thank you very much. We feel we have a lot in common, as well as a lot to learn from you, but particularly that focus, I think, on prevention. And that focus on non-communicable diseases is a passion for us and has been for a long time. And in fact, the partnership with Ethiopia is probably the one I'm most proud of. Don't tell anyone else. But when I think about the way global health partnerships work, which is to link clinicians, academics in the UK with counterparts in other countries, the Ethiopia partnership, isn't it, Joseph, is one of the most long-standing. And it's wonderful to see Professor David Phillips and Andrew Mortimer, two of the people who are very, very involved from the UK side, here with us today. And what to say about Dr. Yoseph? Joseph, you, the formal biography has already been presented, isn't it, in the invite to this webinar, but you've been collaborating, I think, with Global Health Partnerships with the founder, Professor Sir Eldred Parry, since 2001. And there's a wonderful story, which we haven't got time to tell, about your connection through your father with Professor Parry, going back even further. But you've worked with us, or rather, provided leadership for us in terms of our work on NCDs in Ethiopia, but you've worked also within the Ministry of Health and with many other academic partners, notably Jimma University and many other international NGOs. So, Dr. Yoseph, you really are one of the foremost experts in non-communicable diseases, and if you like, the practical challenges of providing care at the point of need in communities. Foremost experts in Ethiopia. So it's a great pleasure for us to be working with you and for Christine and I to be able to introduce and welcome you to this webinar. So thank you very, very much indeed. Over to you.
Great. Thank you.
Thank you very much, Ben, and thank you, Chris, for having me. Good morning, everybody, and good afternoon if there are people from the Far East. I'm very happy to see my colleagues, Andrew and David, here. They are very cherished and valuable colleagues from UK, Southampton University, who've been there very early while we do this. So they are my mentors in a way, as I mentor other doctors in Ethiopia. My mentors are these two. Thank you for attending, David and Andrew. So the title of my presentation, if you put on the slide, then I will start my presentation. It is Decentralizing Non-Communicable Disease Prevention and Control, Ethiopia's community-led approach to risk reduction. It is a long story, but I'll try to make it very, very short. And really, the journey started some 30 years ago when non-communicable disease were not really that on the agenda of global health or even WHO, but I'll just deal with, important points, learning points here. Next slide. So global health, next slide, please. Global health workforce. The Global Health Partnership is a 30-year-old organization, and it works on health system strengthening and human resource for health development. I don't see the second slide still, but continuing from my memory. So we follow a model of health partnership that is mutually beneficiary to the North and the South, this UK institution and Ethiopian and probably also other low and middle income countries. We work very closely with the Ministry of Health. That's why our programs are sustainable, as well as we work on local priorities. We have extensive experience, GHP has extensive experience on policy work and also facilitating international health and engagement. We also work with the UK government and officially related to the WHO, World Health Organization. There is a technical problem. It is stuck on the first slide. I don't know, but I'm continuing for the sake of time. my slide still stuck on the first slide. Maybe. So the objectives of my presentation, until the slide comes back, first is to tell you about how we help support health extension worker, community health agents, primary health workers to reduce risk. So to the third slide, please go back to the third slide, slide number 3. Yes, here. Go to the second, next slide, third slide. Yeah, here. So the objectives is to tell you about the decentralization, how this helps health extension worker, and also to highlight the importance of training and mentoring in keeping quality. Next slide. Expected outcomes of decentralization of NCD or a primary care NCD. What are these? One is universal health care coverage. Our population to physician ratio is 1 to 6,000 almost. So you can't achieve a universal NCD care with only physicians. Also, NCD used to be in the domain of highly specialized doctors, not frontline workers. Therefore, the ratio there is 1 to 90,000, even worse. So it is impossible to achieve it with specialists. Therefore, decentralization is inevitable. Quality of care is very important because a lot of people complain that NCDs are a domain of specialists, highly trained doctors, and you may compromise if you decentralize. So to mitigate that, that concern, which is legitimate, you have to have training, mentoring, and constant follow-up. Finally, we believe that decentralization also helps the care, quality of care given at referral hospitals and by specialists. Because if they are overloaded with the number of patients they see, if, for example, if one cardiologist takes care of 50 patients per day, then that's not quality care. He should not probably look more than 20. Therefore, he should not spend time on prescribing, filling drugs, or even counseling, which can be done by nurses and other mid-level health workers with task sharing. Next. So what are the public healthcare approaches that we are utilizing even before the HIV era? And these are very common for HIV because HIV it's an infectious disease. It's a lifelong chronic disease. So it's similar model with NCDs. So task sharing, not task shifting, because task shifting implies task dumping on middle and frontline health workers. We have to simplify these tasks and you have to standardize them, put them in a protocol, and then train this health worker on these tasks and keep on mentoring them, supporting them so that they deliver it. And with repeated practice and mentoring, they become more or less better and better. Supportive supervision is important because they need essential supplies for their patients like medicine, point of care, diagnostics, and other essential supplies. Community engagement is very important. Non-communicable diseases, as you know, are asymptomatic, and patients do not have more incentives or motivations to go to a health center and screen when they do not feel sick, to take tablets when they do not feel sick, to visit big hospitals when they do not feel sick, traveling long distance and spending days in towns from their farm. So community engagement is very important. People have to know, have to educate that those are asymptomatic. Tomorrow, this problem might explode and may be irreversible. Continuous data collection evidence is important. Are we doing harm? We are trying to do benefit by creating access, but are we doing harm to quality of care? So we have to take care of that by collecting evidence. Finally, the North to South partnership that I mentioned, even South to South partnerships are important. The West developing countries, it's been over 100 years struggling with NCDs, but for developing countries, probably it is 2 decades that we are really become aware of it as important health problem. So there's a lot to share, but the context is different. It is in the poverty setup, in infectious disease as a cause of many NCDs, and also limited resources. The private to public partnership is becoming more important in NCDs as we're not finding a lot of funds from governments, but rather from private sources, private charities, private companies are now our supporters. So this is also an important area. Next slide. Just one story to tell you. I've told Ben this a lot of times, so he's allowed to go to sleep for 2 seconds. So this is a story of case. He is a 35-year-old young man. He's a VIP, I call him. He's a very important person in the northern rural place because he's a director and a teacher of middle school. And a lot of children of farmers want to become doctors or engineers. He has to get them to high school and then to college with good education. So another point is that he stayed long in rural areas. A lot of young people really use it as a bridge. They don't take teaching as a lifelong profession because of the low pay and less prestige it has. So one day he injured his foot in a farm. And he cleaned it and stayed in his porch, and the health extension worker appeared from nowhere, and she told him that it's a dirty wound and he has to go to a health center. So he obeyed that recommendation and went there. The nurse there cleaned him up and gave him tetanus toxoid and also antibiotic treatment, dressing, and sent him back home. But a week later, he returned back with a swollen, hot foot, with fever. Obviously, complication has occurred and no healing. So the nurse trained in diabetic care suspected this could be diabetes. That's why he's not healing. Let me check his the blood sugar. She checked, it was high. So this is a case for referral, not treatment at the health center level. So he went to the nearest referral hospital, which was Gondar University Hospital. There he was managed, sepsis was managed, his life was saved, decay was managed, his life was saved, amputation was prevented, disability at this age. And once he was stabilized, he was screened for complications, heart, kidney, eyes. And in the eyes, one of the hospital nurses operating the ophthalmic camera detected retinopathy. They usually take a photo and give it to a doctor, and the doctors make the diagnosis. They don't have enough time to do the ophthalmoscopy. So then finally his vision also saved by laser treatment. So this is a story, a contribution of everyone in the task shifting process. Next slide. So the health extension worker referred because she was afraid of tetanus. The nurse at the health center level detected that this is a wound complicated. Probably he may have diabetes and diagnosed it and referred because it's not something that it can be handled there. Then finally the specialist. So this task sharing process is very important. Next slide. Next slide, thank you. So the health extension workers they are frontline health workers. They work in the community they live in. They are recruited from the same community that they live in. So in order to retain them and keep them longer, because staff turnover is always a problem in Ethiopia, to ensure access, they ensure access to healthcare by going door to door and advising, giving education, and they enhance early detection and referral. They also enhance community engagement by recruiting peer educators, cancer survivors as champions, or opinion leaders like religious leaders and so on. They also do health promotion and work. When they go house to house, they teach about risk reduction, which I will talk about later. Next slide. The next level are the nurses. Up until 2006, it's only nurses that populated our public health centers. And they were not prescribers, obviously. So you have to train them to screen, diagnose, initiate first-line treatment, recognize complication and referral, as done in earlier slides, and also mentor the health extension workers. So since 2007, Gregorian calendar, there is a career structure for nurses to become prescribers, to become to study 3 more years and earn their bachelor in science as a physician. So a bachelor degree physician, that's one career structure that has developed because of such needs. Next slide. So the hospital nurses also participate in diagnosis. Here you see ophthalmic camera operating nurse that detected retinopathy earlier, and also another nurse trained in spirometry to evaluate and detect, differentiate between COPD, asthma, and send the report to the physician. So this is another role of nurses in the hospital level. Next. So eventually patients are also need to be part of the management team as they have the disease for a long term. If we teach them strategically and empower them, they will help us manage themselves. Next slide. So in a diagram, the community health, the health extension worker, they do 3 important things: health promotion. They educate, they give information, and they advise, and they do screening also. They check the blood pressure in those people above the age of 40, for example. They do blood sugar examination in those who have high blood pressure or are overweight or obese or family history. So not just, screening everybody. It would be a lot of waste of time. And then they give lifestyle interventions. Risk reduction counseling to those who are pre-hypertension or pre-diabetic, and refer all those that have hypertension as such to be managed, confirmed at the health center level, where they are also put on first-line treatment, tablets usually, and then sent back to their home. And at home level, they continue, the health extension workers continue to follow both those on pharmacological treatment and those non-pharmacological treatment, risk reduction. I will talk at the end about what we have surveyed. Next slide. So training is very important, as I mentioned, to maintain quality, and mentoring enhances that, because training is done once a year probably, but mentoring continuously over the year. Therefore, it is a follow-up of the training. So until they become perfect, it's like on-job training. Next slide. Mentoring in the NCD context, we started with clinical mentoring initially, but later the supportive supervision that I talked about becomes a programmatic mentoring. So during mentoring visit, there is somebody from the health bureau checking whether the mentee has all they need, medicine and diagnostic. Then the doctors from hospitals mentor them on their skills. They observe their skills, and they also audit their records, and they have case discussion with them whenever they visit. So to do this, we select good mentors from each hospital, primary hospital, train them in the state-of-art management of each disease, but also in coaching skill, teaching skill, and leadership skill, because all things cannot be solved with money alone. Something can be addressed with mentoring and leadership. So this is how we apply mentoring in the NCD context. Next slide. So we train the mentors first after selecting them from primary hospital. These are young GPs, physicians, 2-3 years after graduation, 4 years. They themselves will be mentored by specialists from big hospitals like in Gondar by, for example, here Dr. Shetai, and in Jimma, Dr. Tardese and others. And the training is also done by senior people, but they're supposed to go back and train the health center staff and also continue to give them same mentoring. And the nurses again will train the health extension workers, and they keep on mentoring them. So it's a cascading kind of training. We use nationally, we have developed with the Ministry of Health modules, standardized modules, which are updated every 3-4 years. And also monitoring evaluation tools, again prepared. So all is used, all materials that we use are endorsed by the ministry and owned by the ministry. Next slide. So supportive supervision, mentoring, some pictures on training of health extension workers, and health extension workers with t-shirts in green participating in campaigns, in this case a marketplace where they check the blood sugar and the blood pressure. So in addition to door-to-door screening, we also support them to prepare campaigns such as this one, where a lot of people come and get screened. Next slide. So just to give you a highlight, between 2018 to 2021, we have implemented in 15 hospitals and 45 health centers, linking one hospital with 3 health centers throughout the country. Our objective is to create a model that the Ministry of Health can replicate, and not really to cover the service coverage, because there are about 3,000 of these facilities and we are just dealing with 60 of those. But after us, other partners have come into the picture, interested in replicating this, and by 2023 the total number of these model sites for the Ministry of Health to use as a demonstration site reached some 300, and it's increasing every year, and the government is also investing its own to replicate this model. Before 2080, that is between 2010 to 2017, it's a time of advocacy to the ministry. So it is a time of dark ages where we were developing guidelines, policy, as well as training materials, modules, and so on, hoping one day we will have the funds to implement. And the first fund came from Novartis in 2018, and later AstraZeneca and other private companies came in supporting other partners. Next slide. So just to give you an idea, some 700,000 people were screened, and some 54,000 people were put to treatment. And over 1,000 health workers who are trained, and we conducted over 450 supportive supervision and mentoring visits. Next slide. The last 2 years, we are engaged in, health extension workers. There was a great challenge. The health extension workers have work overload. There's no clear strategy how they enhance their role in NCDs, and their contribution was very minimal to bringing patients for care. So we thought, what is their problem and how can we support them? The areas we identified was in community engagement. So one strategy, just one strategy. We don't have a community engagement strategy for non-communicable disease that much, but we are in a process of developing one. So one thing is, why don't we use school children? Write them inspiring stories and add something in those stories about hypertension, diabetes, asthma, epilepsy, and once they are inspired, they go home and tell their parents about it. And the parents don't listen, they can also say, I want you to live long enough to see me graduate from college. I think that's a powerful way of tricking the parents to come for screening. So this kind of strategy is the school helps the health extension workers in the short term. In the long term, children will become adults in 10 years, 15 years. And that means they have already developed a favorable attitude against risk factors, unhealthy lifestyle, diet, lack of exercise, and also about smoking and alcohol. Next slide. So in Addis, we are experimenting, in Addis and surrounding rural areas, we are experimenting with how to help them with community engagement strategies and also how to enhance their effectiveness and efficiency. They have 15 packages. They deal with maternal child, nutrition, children health, TB, environmental health, so many. So how can we make them efficient with all this load? Also, they spend a lot of time on data collection, compiling, reporting. Almost 50% of their time during the week goes into data collection and compiling. So how can we make that efficient? So digital solution again comes into the picture. They spend 7 days a week in a hotel to be trained. That is keeping them away from work a long time. So how can we use digital self-directed learning offline, online, by training them on how to handle digital solutions? So with that, we reduce the number of trainings to 2 days from 7 days, and they can study at home and they can continuously use it that throughout the year as well. It's interactive tablets. And also for data collection, digitalizing their paper-based data collection to digital, so that they can it can compile them reports and cut the time that they spend on data collection and instead spend that time on NCD and other screening. So we use this strategy. So also they go door to door and also checking, following up their patients who are pre-hypertension and pre-diabetes, and they check whenever they have the resources for diabetes, their blood sugar, but also they check the blood pressure every time, and they see, your diet is good, your exercise is good, it has effect on your blood pressure. Or maybe you're not exercising well, and you're not strict on your diet, so your blood pressure is not controlled, so you have to go to the health center for treatment. So we have some data on this, which is not yet published, so I cannot show you, but in few months we will have that paper coming out. Next slide. There are a lot of challenges, but these are learning opportunities. Turnover is one. Monitoring, evaluation, learning, quality of data, community engagement. We have to find still more feasible strategies, quality of service, and also the referral system. The journey that I mentioned at the beginning of the patient's journey through health center up to the hospital is not always smooth, because that patient has a very serious illness, he has motive to go through. But if that patient was not asymptomatic, we really go through that path, because we have to facilitate it to be very smooth, and it is not that smooth. So sometimes patients disappear at one or lowest or middle level. So there is a lot of work on that area. Next slide. So what can we do? A lot of things. We can expand to new sites and create more models. We can explore and pilot digital solutions more, which I told you about. We can embed national mentoring scheme in the national system. We are already working on a national guideline to standardize national practice. Increase community engagement through various strategies. Medication equipment supply chain, there's a lot of work on that area, because there's sometimes interruption of medicine as well as interruption of the point of care diagnostic reagents. Also, the referral pathway is something we can work on. Next slide. As a future ambition, we are working on health promotion and primary treatment, secondary prevention, primary and secondary prevention. How about tertiary preventions, like rehabilitation also can be taken to the community. Palliative care also can be taken to the community level, and we can think of also including those pillars of healthcare and decentralizing them to primary care in the future. Next slide. Thank you very much. I have arrived to the end of my slide. So I will give back to Ben. Thank you.
Ben,
I think I'm giving back to you, Christine.
Well,
wow.
What a fantastic presentation. Thank you. And one of the reasons we began these seminars was initially with very much London focus. They were pre-COVID. We gave people wonderful breakfasts, and and people met and shook hands and exchanged cards and things that we're not doing now. But we didn't have that many people in our rooms. And one of the reasons for them is my passionate belief, which you've demonstrated, that other countries so many countries can learn from each other, and often we're so bad at doing that. And I know that's a big motivation and part of the soul of global health partnerships as well. And so many of your messages resonate, and I'm sure people will be wanting to ask you questions or make their own comments. So please indicate by putting your hand up or putting something in chat, but most of all put your hand up, and then you can ask your own question. And I suppose I wanted to ask you, you've given us some hints, but in C3, one of our programs that we're most proud of is our community engagement program. And both with that, but also with our work with healthcare workers, actually engaging people is really difficult. People have their busy lives, they don't hear the messages, and you've touched on that, Joseph, but it'd be really interesting if you could expand a bit on your methods of engaging people, often in some of the most difficult areas. I think you're on mute.
Yes. Thank you, Christine. Yeah, it is quite challenging. As I mentioned, one of the the simple instincts that patients have is I don't feel sick. You have discovered something. It doesn't make sense. You have high blood pressure, you tell me, but I feel quite fine. So this is very difficult. Then next step is some would say, okay, I accept whatever you say. What next? And you say medication. Oh, no way. I don't feel sick. I am not going to take a tablet. Other people say, okay, I will start a tablet. Then they get bored after some times, obviously. What's the point of taking this tablet? So it goes on, the problem, because early on, NCDs are asymptomatic. So one of the things is that during training, we tell the nurses is don't tell them they have a hypertension disease or diabetic disease. It's better to tell them they have a risk factor. And something that explodes. It is a time bomb that explodes later, unless you work on it now. That may be a little bit more reasonable than saying you are ill, you have a disease. So this is one area on the psychology of our people, but we have to be very patient. And, it's not going to be an overnight thing. So we came to the children's strategy because of that. Children will be more trusted than us. And also children, as you know, in business also, people show a lot of toys and make their parents buy it. So we are using that strategy. Children are powerful. They say, Mom, I want you to stay up to my graduation. That's very powerful motivation for patients to screen. Mom, I want you to see my children. I don't want you to die prematurely. So I don't know whether we are being very probably nasty or whatever good word you can have, but we are trying our best to get their ears. Thank you.
Yeah, I think nasty has to be put on one side, really, because it's so important. I agree. And does money make a factor? Certainly with smoking, one of the tactics we've often used is helping kids understand what could be spent with the money if their parents stop smoking, and that's sometimes quite amazing. Yeah. Other comments or questions? Katie, I can see you somewhere, so unmic, unmute, and far away. Great.
Very good. Hope you can hear me. Good morning, Dr. Yoseph. Lovely to see you. Great to hear that this is expanding, and it all sounds it's fascinating to hear all the work you're doing. I was wondering sort of how scalable this is. So you mentioned private sector funding, I think, from a couple of the pharmaceutical companies, but I mean, I think we all know that ultimately sustainability really depends on government involvement and government funding. And I was wondering what sort of support you get from the government, and is that likely to be long term? Is that going to build? So how engaged in this and how receptive is the government to what you're doing? Because it sounds so effective, but as we all know, NCDs are long term, so often you get these cash flow problems at the start. I'd be really interested to hear. I think financing at the moment is such a big issue worldwide. It'd be great to hear your experiences.
Thanks, Katie. And for those people who don't know Katie, she coordinates a group of NGOs working on NCDs internationally, so of which Global Health Partnerships are a member. Over to you for a challenging question, Joseph.
Thank you very much, Katie. That's a very good question, and it's important to acknowledge the government's commitment. You see, earlier from 2010 to 2017 or 18, there was no funding. As usual, governments expect foreign aid from USAID or UK aid, FCDO, and so on. But that did not happen, so we changed strategy. But meanwhile, the government was very collaborative. We had a policy changed, supportive of NCDs, a framework for cancer and other NCDs. So this was a sign the government is interested. We developed all the tools, country tools, modules, training modules, primary care guidelines, including it in the indicator of the national monitoring evaluation. All these are signs of commitment by government. Now, the past 2 or 3 years, there is amazing thing that we never expected. We were talking about, in towns, lanes for cycles, parks, and for children, playing fields and so on. Well, we were just speaking this, we thought it will never happen, but amazingly throughout the country at this moment as I speak, these things are happening. If you come to Addis, it's unrecognizable. Of course, a lot of people object that this is not a priority, but you have cycle lanes in Addis now. You have walking lanes in Addis. You have parks for children playing. So it is a miracle. Of course, a lot of my countrymen, many, may not be happy with me saying that, but from the health perspective, this is something great. Other things, the government has put laws, taxes on salt, sugar, have banned hydrogenated lipids, and have put a lot of tax on alcohol and smoking. All these are important commitments, and to use revenues for NCDs. As I mentioned earlier, we worked on about 300, partners worked on about 300 facilities, but the government currently is engaging in training more and more healthcare workers. The money we put in is not that much, really. It's not, we didn't go there with big money because, as I told you, it's private charities and they don't give you huge amounts. So whatever we did was sustainable. We used the modules that the Ministry of Health used and so on. So now there is more confidence in handling non-communicable disease because that health center deals with it. So how do they do it? Then we can do. The other thing is the career structure for nurses. They have become prescribers now. So we have nurses, BSc training, become physicians. So they have the knowledge to handle. So there is more confidence of the health center. And though things are slow, it is a very good, promising and sustainable. Even if we are not there, I'm sure things will continue to be replicated. Thank you.
Ben, you were coming in with a question, I think, and
Well,
then Glenn Stewart.
Thanks so much. That's so interesting. Joseph, I thought one of the high points in terms of influencing or partnering with the government was the development of the PAC approach and the integration of NCDs into the PAC approach. I was wondering whether you could talk more about that. And then, as you know, the passion for us, the elephant in the room, apart from the money, which I think is such an important point Katie's made, is workforce. And we are all, aren't we, every health system facing that workforce challenge. And you did touch on it, but I wondered if you could talk more a bit about that.
And before Joseph does, Glenn, ask your question as well, and they might roll together or they might not, but you might forget if I leave you too long. So Glenn, over to you.
No, sorry, I'm just trying to remember. I seem to remember reading a study, I don't know when, but fairly last year or so. I seem to remember it saying that like a third of Ethiopians had an NCD, which I found astonishing. I thought that prevalence was just remarkable. I thought, I might be like completely wrong here and just, but I thought it's probably quite a young population. Their sort of economic development would mean most people probably haven't had the time to develop NDCs as we do in the sort of developed nations. And if that's true, like how can you move to preventing them actually occurring as opposed to trying to sort of like treat and manage? Because like there's no way in the world, even a sort of pretty developed country can sort of manage that sort of burden of health and illness. So what can you do to stop NDCs actually developing in the first place?
And if my memory is right, Glenn, you're in public health in one of the London boroughs. Is that, have I remembered right?
Yeah, that's
yes. Great.
Enfield, thanks. Yeah.
Thanks. So challenging questions, both from Ben and from Glenn. Joseph, over to you for the answers that we're all looking for, I think.
Sorry, my voice transmission was breaking up on the second question of Ben and Glenn, so they will repeat their questions briefly for me. But
Okay.
to respond to PAC, yes, PAC is a primary care kit for clinical treatment guideline, which initially was designed in South Africa, Cape Town, for primary care. Then it was scaled up in Botswana, and our minister visited there and saw how valuable that is. And we also brought it to Ethiopia, and in the context of our primary care, we modified it. So we are very grateful to our partners in South Africa and Botswana. And it is very useful for primary care. It's a protocol. Everything is there. So it is an algorithm that helps for diagnosis. It's an algorithm that helps in treatment. NCD is incorporated in that. You have everything. So if it is a great work. So what we did in Ethiopia, exceptional thing is we tried to develop software so that for our health worker, instead of flipping through that guideline in front of patients, they can flip through it on their desktop and refer as the patient speaks, so go through the algorithm to make a diagnosis and make their choices of medication and consult if they have difficulty. So that is a very good tool for primary care. Thank you. So Ben and Glenn, please repeat your questions.
I put mine in the chat box, Joseph. I hope that's helpful.
Okay.
And Una's raising a question. Una, who's been masterminding our technology. But over to you, Una.
There are 2 questions in the chat box. I don't know if they've been seen. So one from Paul saying, thank you for the excellent presentation. And building on Katie Cooper's question, how do the partners involved in replication in Ethiopia interact with each other, learning, practice and policy influencing? Are there lessons about this community or partnership network that we can share when considering scalability and sustainability in other locations? So that's the first one. And the second one from Andrew is, can you comment further on the financial cost of NCDs, in particular the financial burden that patients face? And what is the progress for community-based insurance schemes and other initiatives to make continuity of care more achievable for those who have a very low disposable income?
Thanks, Una, for highlighting them.
So let me deal with Glenn and Ben's question first. Ben's question. The shortage, health worker shortage, of course. Even now, health extension workers are learning nursing and going away from the community. So we have to keep on training more. And as I've mentioned, there is already workload. There are 35 to 40,000 of them throughout the country. And it is appearing now that there is a lot of work they are doing, and we need more health extension workers. So it is a challenge. Nurses are also going into, public health after studying, becoming health officers also. Career structure is there for them to go into public health and offices. So we have to train more and more nurses coming up. Physicians, the same thing still. Our population to physician ratio is very short, as I have already mentioned. So that challenge is there.
Right. And Glenn's question is about the youthfulness of the population of Ethiopia, and yet the high level of NCDs.
Yeah, the NCD, the level of NCD on national screening, but it is a very small sample. Hypertension could get from 24% to 30% in above 18 years, starting from 18 above. And diabetes, about 6% in those above the age of 18 again. So it is quite high. This is camp screening done by the Institute of Public Health. So it is quite high. A few years back, this was a little bit, for example, a survey done in Jimma, few years back for diabetes, it was less than 3%. And for hypertension, it was around 15%. But within probably another 10 years, what the survey shows is an escalating prevalence.
So the question would be how to stop that prevalence rising.
Yeah, I think one of the reasons is I think the changes. What are the changes? If you say one is urbanization. A lot of people have become sedentary in the towns, for example. Smoking rate has increased, alcohol intake, beer companies, a lot of beer companies propping up. And these are some of the factors. So it is educating the people and making, increasing, I mean, what we are advocating is increasing taxes on smoking, alcohol, banning import of foods, I mean, oil that are saturated fat, and also banning local production of food items with hydrogenated, and companies have to declare their salt and sugar contents. You know, we are trying to bring laws that make it difficult to produce these things. But I think education is the most important thing, making people aware of the dangers of whatever they are eating and buying.
I'd agree with a lot of what you said, but I don't think education by itself has ever had much effect on anything. I mean, how many smokers don't know that smoking's? Well, how many smokers don't know that smoking is bad for them?
Yeah, making it expensive also. Laws, making it expensive to buy those things, and making it expensive also for manufacturers. Laws. I mean, as you said, eventually.
Can I raise an issue that's my C3's current really big priority, which is the whole question of oral health. And at the moment, C3's been doing quite a lot of work training nurses particularly, but also community health workers and teachers around the importance of oral health. And I've been shocked both in my own country, but in so many others, that it never gets mentioned. And yet, in many ways, it's such an obvious risk area because everything we eat and drink starts there. Our smoking habit starts in the mouth. And I wondered how much, Joseph, it was figuring in the work overall in Ethiopia to tackle NCDs.
Sorry, Christine, I missed your question while reading the question in the chat, but let me answer one question in the chat,
Sure.
Which says, how do you interact? How do the partners in Ethiopia interact and collaborate? Very good question. Every partner, when he wants to work with the government, has to bring his proposal to the Ministry of Health and get agreement. And it gets agreement only and only if he's following the country's policy, national strategic plan. And the Ministry of Health also makes sure that he assigns my organization, GHP, to a certain facility, then to avoid duplication, the other partners goes to another facility in another region. So this is how we operate. And also we have a review meeting. The Ministry of Health prepares a national review meeting every year for NCD and other diseases. So we gather there and interact, give our reports, and share from our challenges. The other thing is also there is technical working group at the Ministry of Health level from each partner. Experts like myself and my colleagues go there and meet every month or 2 months, and together we edit guidelines and we edit the monitoring evaluation tools together. This is how we work together. Christine, back to you, your question, and my apologies. I don't have a multitasking skill.
Not at all. And I'm conscious of the time ending. So my question was about oral health. But I'm also aware that we're very nearly out of time. So, and there are lots of questions, but also comments in the chat. And we will go through those and share them with Joseph if that's the most relevant source, or respond to them, because there are many interesting points and comments that we look forward to following up with everybody. Thank you all for joining, and congratulations to Joseph, because everybody stayed. They stayed for the questions and have stayed. And so what a great first seminar of our new series, and really want to thank you, Joseph. Thanks to Ben and Global Health Partnerships as well for joining with us and for the introduction. And we will let everybody know about our October seminar, which we will promote shortly, respond to many of your questions and comments. But most of all, Joseph, a really big thank you for something that was really interesting on its own, but so resonates with other countries. And I'm just thinking everybody from the UK now spouts the 3 messages from the government's new 10-year plan about using digital, about moving from hospital to community, moving from treatment to prevention. And I think you gave us some really interesting examples and inspiration to address those in each of our countries. So a big thank you. Good luck with the work, and most of all with getting the funding. And all of us, picking up a comment from Katie, will be interested to see whether the high-level meeting at the United Nations later this month really helps move this big agenda forward, which I think everybody on this call knows is so vital to the world at large. Joseph, thank you so much. And thank you very everybody
much
for
having
coming.
Me.
Thank you.
Thank you.
Thank you.